This symposium is part of a big project that the university has with CAPES, which is the financing of the post-graduation in Brazil. And this project intends to promote internationalization of the post-graduation programs in Brazil. And UniFesp has defined 6 priority areas for this development. One of them is longevity. In this area of longevity, we have very many researchers in the university. We try to put together in this symposium the ones that have an affinity with the project that gave birth to this scholarship or this grant from CAPES, which is a project devoted to health promotion of in old age, promotion to produce functionality and longevity. And you're gonna hear today people that working on those lines, and some very important researchers that joined this project from the University of Missouri. So we have Dr. Eduardo Simões, who is head of the Department of Health Management and Informatics, who brought with him 2 colleagues, Professor Mihail Popescu and Professor Amin Zorabian. Both will be talking to you this morning. We have the pleasure of having the head of the Department of Preventive Medicine and, of course, the Prorector of Research, Post-Graduation and Research of UniFesp, Professor Lia Bittencourt, that would like to give a few words to you.
Primeiro, em português, eu gostaria de dar bom dia, bem-vindo a todos e todas, dizer que, estando como pró-reitora de pós-graduação e pesquisa na Unifesp e, por isso, gestora do programa CAPES-PRINT-UNIFESP, dizer que é uma honra para nós, na Unifesp, a Escola Paulista de Medicina, sediar essa semana, que eu estou vendo assim, tão produtiva, né, e enriquecedora nas atividades de longevidade e funcionalidade, parabenizar o nosso grupo de docentes e pesquisadores da Unifesp, que sempre nos prestigia e nos coloca em destaque nessa área. Agradecer os outros palestrantes das outras instituições, né, que eu vejo aqui a Unisul, a Universidade Federal de Santa Catarina, e os nossos palestrantes internacionais. Então, eu desejo que vocês tenham bastante apoio da nossa instituição e que seja um simpósio e uma semana bem produtiva. Welcome. I would like to thank our international speakers for attending this week of activity on the theme of longevity, and say that UniFesp is honored with this partnership, and I wish all of you an excellent event. Thank you.
Thank you, Lia. Well, okay, so without further delay, we're going to start the presentation. I'll make an opening presentation, and then afterwards, I'll give the word to Professor Eduardo. Well, as I said, this theme, longevity, has as the project that supported the grant from CAPES, the idea of health promotion to prevent the functional decline that is inherent to the aging process. So I'm going to show you how we get to this line of research of promoting health for functional longevity. Health promotion in this aging paradigm. Okay, I'll start by quickly going through the process of aging in Brazil, just to give you an idea of how fast and how intense this was. Brazil, since 1950, and this period from 1950 to 2020, infant mortality dropped from 150 to 15 deaths per 1,000 live births. Life expectancy went up 30 years, from 45 to 75. Fertility dropped from 6.2 children to 1.8 children per woman in reproduction age. We are actually the 6th largest elderly population in the world, and very soon you're going to have more than 30 million people over the age of 60. The 80-plus group is the fastest growing age group in Brazil, and the demographic window, unfortunately, is about to close because we didn't took advantage of this during a long period. And the 60-plus will surpass the people from 0 to 15 age group by 2040, which is a gloom perspective in terms of the social balance. This is the survival curve that shows that a country like Brazil is probably experiencing the enlargement of this area. That means people who are alive but carrying a chronic disease, and this orange spaces the people who are alive with a chronic disease and a disability as a consequence of the chronic disease. Agora que eu estou vendo como é que é esse negócio aqui. In terms of the epidemiological consequences of this aging process, we have cardiovascular diseases assuming the first cause of death. And they were 10% of deaths, now it's almost 40%. Infectious diseases went down from 40 to 5%. 95% of the population have a chronic disease, and that's the thing, everybody will have a chronic disease to take care of. 95% at least 93% use at least one chronic medication, and 30% experience some dependency in the activities of daily living. Primary healthcare structure still for maternal and child care, and 60 plus, that represents 80% of the population, already occupy 16% of hospital beds and cost to the system 25% of everything that is spent in hospital care. Brazil also has a high proportion of polymorbidity. 15% of the population has 5 or more chronic diseases, and 20% take at least 4 chronic medications. Severe dependency in daily life affects 15% of this population that has trouble to execute 7 at least activities of daily living. And so all this situation combined with 30% of the population living in very poor conditions, that gives an explosive combination to be faced by the health system. We started in 1991 a cohort in this area of Vila Clementino to study how aging was being processed in the Brazilian population and what would be the risk factors for aging well or not aging well. We started that in 1991. In this area, that is the area where the university is right in the middle, we did several waves. The first cohort, starting in 91, went until 2001, and then in 2006 we started a new cohort that's been going on. These people that lives in Vila Clementino are people from middle upper class with very high levels of education, like 80% has more than 12 years of education, which is, for Brazilian standards, completely out of the curve. But anyway, we can look at this population as the best we can get in terms of the aging. You know, they have good education and good economic status. But even though 33% of this population refers at least 5 chronic diseases. And these people have, as we see in the rest of the world, a rate of dependency in the so-called activities of daily living, from almost 50% that couldn't do the shopping alone to 5%, 4% that needed help to get in and out of bed. We draw a line here of high dependency, meaning that these activities, personal activities, show a person that has high dependence and probably needs help 24 hours at home. And if you put all together, we're going to see that 16% is below the high dependency line, meaning that in a city like São Paulo that has 1 million people in this age group, meaning 1,600 people needing this kind of support in daily life. After following this cohort, we could see the causes of death. Like almost 10% die in the period. And all these conditions here promoted a higher mortality rate, like being a man, being very old, rating their health as bad, being severely dependent, depressed, and with cognitive impairment. When we did the multivariate analysis, and this was a work I've done with Dr. Eduardo, that at that time already collaborated with us. We did a logistic regression and found out that from those 10 factors affecting mortality, the ones that really were independent was age, gender. Unfortunately, men controlling for everything still die more than women. Hospitalization last year also hold down in the equation. And cognitive function, impaired cognitive function, double the risk of dying, and being severely dependent made the risk of dying 3 times higher. So these 3 factors we can't do anything about, but we can't do something about cognitive function and independence. So we start working on those lines, trying to see how we could help people to age with a good cognitive function and with a good independence in daily life. We start studying factors associated with functional loss. We start looking at the survey, the cohort in England that is the oldest elderly cohort in the world, and they also found an association and this was a work we done together with Dr. Eleonora, who is here and will be talking to you later on, and André, who is also here, that were working with Michael Marmot at that time. We also look at other elderly populations to look at the factors affecting functional status. And so we decided to look more carefully to the activity of daily living questionnaire, which is the way of assessing functional loss. So the ability to do the common activities of daily living without help. So we decided to see if we needed all those 15 activities. So we did a survey to look at what were the minimum set of questions to look at dependency. And then we look at the validity of these questions to really identify people who were in need for help. So how many people that say that they can't have a bath alone, do they really need that help? So we did a survey that tried to validate these questions to have a valid instrument. And we recognize like 3 or 4 activities that had a good specificity and a good sensitivity, like walking 100 meters, being able to dress up, being able to shower by themselves, and ability to get in and out of bed alone. So these 4 activities are very valid to identify people who probably need help in their daily life. Well, this is for physical abilities. Now, for cognitive abilities, we've been working with an instrument called clinical dementia rating that can classify people as normal, as borderline for dementia, and demented. And this population showed that 8% were already demented, almost 60% were normals, but we had this almost 40% of people that were in in the middle of the road to convert to dementia. And this is our chosen population to work with, because we can't do anything about dementia as it's installed. So we decided to work with this borderline population to see if we could postpone the conversion to dementia. First, we had to validate this scale, dementia scale, for the Portuguese, and we did that work like 10 years ago. And then we did a follow-up to see who would convert to dementia. We got people from CDR 0 and CDR 0.5 and followed them. And we realized that the main risk factor for converting was having a CDR 0.5 compared with having a normal CDR. So people with a CDR had almost 4 times higher chance of converting to dementia. And if the box score, which is something from the instrument, if you have a high box score, you have almost 6 times the chance of converting to dementia. So at this point we said, well, we have a valid instrument to assess functionality, and we have a valid instrument to assess cognition. So let's go. Let's go and see if we can answer these million-dollar questions here. One is, what's the best strategy to make sedentary people turn active? So as a way of improving functionality. How do we change people's eating habits? Good, big question. How do we promote cognitive stimulation at a populational level? How can we limit environmental stress? Oh, that's trouble. And how to improve compliance to chronic medication? This is probably the one question that is doctors' responsibility to convince their patients that they are taking the pills, not today, not this week, but the rest of their lives. Time to tackle the first question about how to make sedentary active, we start studying all the health, the activity promotion programs, again in a project with the CDC in Atlanta and St. Louis University, due to Dr. Eduardo was at that time in the CDC, and he financed this GUIA project that went to see all the physical activity promotion programs in Brazil. We study all of them, and we identify programs like the Academias da Cidade in Recife as a very effective way of making people move. But then we look at our cohort, and we had this MSc student applying the EPAC, which is an instrument to evaluate physical activity. And she concluded that in terms of physical activity in leisure time, only 27% were active and 57% were inactive in leisure time. So, and this doesn't differentiate from the rest of Brazil and probably the rest of the world. It's very little, it's more or less a third of the elderly population actually can be considered active. So then we try to intervene to improve and to increase the number of people being active in leisure time. We did this first work with a PhD of mine, and we tested 2 interventions. One was having a physical educator twice a week for the elderly to come and do physical classes twice a week, as I said. We had apparently a good result when we saw that the people who had access to the physical educator improved quite a lot their physical activity compared to people who just received a medical recommendation for physical activity, and compared to the controls who did not receive any instruction for that. The trouble was that after a while, when the intervention with the physical educator stopped, the elderly also stopped doing exercise. So they went down and joined the same curve of the people who received the promotion of the doctor. So I said, well, that doesn't work. You know, you can't keep people doing physical education classes forever. So we tried a different strategy. So we did a randomized control trial in a primary health environment, promoting leisure time physical activity through two strategies. One was we did two groups. One was the counseling group, and the other one was the referral scheme. The counseling group was the same doctor saying, look, you have to do exercise. This group here, we had a physical educator who had in hands a map of our region, Villa Clementino, identifying all the places where they could possibly do physical activity, either in a private basis or in a public basis. But with the physical educator saying, look, where do you live? Oh, you live here. So in a radius of 500 meters, you can find this, this, and that to do physical education, to do physical activity. And I'm going to call you every month to see if you're doing. Well, this proved to be very effective because people here were all in the same situation, low physical activity and no action taken. Then we follow them without any action for a while and repeat the evaluation. They were still in the same position of physical education, physical activity. So after the intervention, the group with the referral scheme went up and sustained, because here the intervention stopped and sustained the physical activity, whereas the people with the medical advice didn't do, and the controls obviously didn't do. So this proved to be an effective and durable intervention to promote people leisure time physical activity. So we said, okay, so now we have a effective way of producing improvements in physical activities. Then we had to look at cognition. So what can we do for cognition? And we learn again from the ELSA study in England that digital literacy, or in other words, being able to play with a computer, has shown to improve cognition, functionality, participation, and health prevention. Anyway, it proved a very healthy activity. So we said, well, we're going to do that. And we followed the lines of Dr. André Junqueira, who was a pioneer in Santa Catarina, in Florianopolis, putting the elderly to play with computers and observing that this activity was very good for their cognition. So this was a novel approach to promoting cognition in the elderly. And then Dr. Eleonora put forward a similar cohort in Florianopolis, and with her cohort, Epi Floripa, she also showed that the digital inclusion improved functional capacity of the elderly there. I said, well, we should do the same thing. So we got a grant from FAPESP, and we built up a LAN house in our center to enable the elderly to play with computers with supervision. You know, we had these students supervising them, not like they do with their grandparents, that they don't explain too much, but there they were just really taking care of them and helping them to become independent with the computer. And the results are good. So that there was a significant improvement in the cognition measurement that we did with the MOCA instrument. So that gave us confidence that it's possible really to improve cognition of these people just by putting them in the computer. So then we came to the billion-dollar question. We were trying to tackle the million-dollar question. Now we wanted to tackle the billion-dollar question, which is, if these health promotion actions prove effective at the primary healthcare level, do they also help prevent age-associated functional decline, which is the main subject that we are addressing here? So this is a more difficult project, because we have to promote two interventions and follow them to see if the expected decline in functional capacity will be less intense than it was supposed to be. So we got again, So then we got this association with Missouri University, with Dr. Eduardo, to place a project that is a joint venture between the NIH and FAPESP, which is a big project, 5 years follow-up, with these two interventions happening, and we hope to be able, first, to be financed, second, that the project will show that these two health promotion actions are able to slow down the functional decline. So that's the way we got to this question. I'm happy that we had this collaboration with all these people that are here also to show their work. And I hope this symposium will help you to identify places where you can help develop strategies for us to age functionally and for a long time. Thank you. Oh, sorry. I need to say that this project, Longevity, is based on two projects: the promotion of health promotion and prevention of the functional loss, and also the project that we have with the immunology department, which looks at the immunosenescence as part of the equation, right? And this longevity part of the CAPES-PRINT joins these post-graduation programs: Saúde Coletiva, Imunologia, Nutrição, Fonoaudiologia, and Ciências do Movimento. Thank you. Intergeneration contact is very important.